Welcome, everybody, and thank you so much for joining this extremely exciting launch of the Lancet's One Health series, which was published in the journal last week. My name is Richard Horton, and the Lancet is my home, and I'm delighted today to be working in partnership with our friends at Chatham House, at the UK Health Security Agency, and with the Pandora Network. That's the Pan-African Network for Rapid Research, Response, Relief and Preparedness for Infectious Disease Epidemics. You're going to hear summaries of each Lancet paper, and we will have opportunities, you will have opportunities for questions throughout the session. After a short break, we'll then reconvene with an expert panel, and we have some amazing superstars for you to illuminate our discussion. A couple of small bits of housekeeping. Please use the question and answer function on your screens to ask your questions, and when you do so, it would be super helpful if you could give your name and your affiliation. This webinar is being recorded and so will be made available afterwards. It's also being live streamed through the Chatham House website, and thanks to our partners at Chatham House for doing that. And please, social media, don't forget to tweet. We want to amplify the messages about One Health to the world. Part of the reason for doing this series is that we don't feel that those messages are sufficiently amplified. So this is our opportunity to do so. Now, before we get going, I want to give the floor to our intellectual leader of this project, and that's Osmond Dar. Thank you, Osmond. Osmond is the One Health Director at Chatham House, and he is also a consultant in global health at the UK Health Security Agency. So, cue Osmond to give a brief introduction to the whole project. Osmond.
Thank you, Richard. So first, good afternoon, everyone. I need to start with a word of thanks, firstly to all the contributing authors across all the papers for their long hours of hard work, their dedication, perseverance and diligence with the whole project. We've had over 100 contributors from every continent, across sectors and disciplines, and we've sort of tried to balance and bring in a diverse set of perspectives. So balancing both young scientists with very experienced researchers. Having said that, we've even managed to include that most critically endangered and elusive of species, in some places being hunted to extinction. Sorry, and that's of course the silver-crested white male professor. So we're really pleased that we've been able to get this big group together. Just in terms global outbreak to contend with in the middle of it all, with many of our contributors also responsible for national, continental, global elements of the response. To help steer the whole process, we've had a couple of people that I really want to thank, Professors Richard Koch, David Heyman, and Ali Zumla, for helping develop the initial outline for the series with me and for providing really valuable input all along as it progressed and matured. Richard Koch really gave us a critical insight into the wildlife, ecosystem, and animal health aspects of our thinking. David, of course, with his decades of experience at the forefront of outbreak control and at the very heart of global health decision-making, has been a really invaluable resource in helping us stay grounded and in keeping with the realpolitik of the world around us. And finally, Sir Ali, who has an infectious disease and clinical knowledge base perhaps as deep as the Mariana Trench. And luckily for us, who also happens to sort of churn out these Lancet series almost on an industrial scale. So that came in really handy. I also want to give a shout out to Pam Das and Tamara Lucas, senior editors at the Lancet, for sort of guiding us and supporting us through the development of each of the papers. Finally, I should also say, I'd really like to thank the One Health high-level expert panel for their accompanying commentary, and we'll be hearing more about that and the work they've done on definitions and theory of change from Catherine Mashalaba, who is on the panel later on in the program. And Catherine is sort of literally everyone's favorite One Health guru, so I'm excited that she's able to join us. In terms of the logic of the series, it was pretty straightforward. We wanted to move from the theory of One Health to its practical application. So the first paper covers the evidence base around One Health approaches being applied in a health security context. The second paper looks at, it's an exploration to help us understand where these approaches are being applied, what do One Health networks look like, are its principles being applied equitably, how are these initiatives structured and delivered, so that explored that. The third of the papers looks at how we're monitoring the effectiveness of building and strengthening health capacity and capabilities. What tools do we have for that monitoring and how might they be improved? And then the fourth and final paper looked at how do we develop a governance system and an accountability mechanism that's cross-sectoral, collaborative, and supports coordination across all of health security. What should the institutional and legal architecture look like, and how can that be strengthened? Finally, in sort of closing my bit of this, I'd just like to say we're really chuffed to have Richard Horton chair this event. So I've got to say a couple of nice things about him. Richard, as I'm sure you're all aware, is the GOAT of medical and science editors. Admittedly, that's quite a niche group, but it's still a big deal. He's a wordsmith, and he at times sort of spits straight fire with some of his blistering commentaries. One of my recent favorites was him coining the term statistical genocide on behalf of a colonized people. I suppose the nicest thing I could say about him is he's sort of like the Dave Chappelle of global health commentary. So we're really pleased again to have Richard here chairing this event. And with that, I'm going to hand back to him so we can get this show on the road.
Thanks, Osmond, for that unscripted introduction. If I'd known what you were going to say, I would have edited you. That's very kind. Let's start, because you're going to hear some really quite revolutionary ideas over the next 50 minutes or so. Paper one, as Osmond said, this is about advancing one human animal environment health for global health security. It's being presented jointly by Jakob Zinstag and Katrin Heitz-Topka. Professor Zinstag leads a research group on human and animal health at the Swiss Tropical and Public Health Institute, and Dr. Heitz-Topka works at the Pan-African Research Consortium Afrique, One Aspire, and she focuses on One Health too. She's based in Côte d'Ivoire. So over to you, please, for paper one.
Can you hear me? Can you switch on my camera? I don't know why I cannot switch on my camera.
We can hear you.
Yeah. Let me.
Please go ahead.
Yeah. Thank you. Hello, everybody. My name is Jakob Zinstag. I'm a veterinary epidemiologist at Swiss Tropical and Public Health Institute, and I work on One Health since 25 years. For us, One Health has necessary conditions, but which are not sufficient. The necessary condition is that we recognize the inextricable linkage of humans with wildlife, domestic and companion animals, and the environment. But that's not enough. To do One Health means that we demonstrated an added value or incremental benefit of life saved of humans or animals, financial savings, or preserved environmental services from a closer cooperation between human and animal health and other sectors that cannot be achieved if we work in isolation. So we have this stringent definition, and we work along this with new methods that measure that incremental benefit. The second pillar is the transdisciplinary approach, where non-academic actors become research partners. Here you see two settings, one on the Lake Chad area in 2005 and 100 kilometers north of Timbuktu, where we work with Tuareg communities. In both settings, we bring together decision makers, scientists, and the concerned population in contextual problem solving. If you want to look at methods of this transdisciplinary process, you see here the website of the transdisciplinary network of the Swiss Academies of Science. Now, how does One Health embed in the conceptual landscape of integrated approaches to health? On the right side, you have the red ellipse of public health. On the left side, you have the green ellipse of animal health. So the intersection is what we call One Health in the narrow sense. This is where we conceptually place One Health. But we have concepts that go beyond ecosystem approaches to health or eco-health or health in social ecological systems, enlarge the idea to the broader social ecological system. Now, One Health definitely considers also environmental aspects. So that's why the yellow dot, which is blurred, includes the social ecological system. Now we have also the planetary health concept, which is rather anthropocentric. I have not read many papers, if any, in planetary health that really address animal health in the same way as One Health does. And we also believe that One Health is the best operationalized concept today of integrated approaches to health. Let me give you two examples. One is brucellosis control in Mongolia. Brucellosis is an animal disease that causes abortion and is transmitted to humans via direct contact or milk and milk products as a consumer. You can control human cases by antibiotics, but with that you can never eliminate the disease. So we were asked by WHO to answer the question if it was profitable to mass vaccinate livestock to prevent human brucellosis. And here is the economics. For intervention cost of $8 million, the public health benefits are only about $3 million. But so if you would be a minister of health, you would say it doesn't make sense. But we interviewed also private patients about their private health cost and income loss. And we estimated also the incremental production of meat, milk, and hides after the vaccination of livestock. And we summed it all up on the right side. And you see the societal benefits of mass vaccination of livestock is 3 times higher than the intervention cost. So One Health pays off. It pays off if doctors and veterinarians work closer together. The second example is from rabies control in Africa. Here we have done a mass vaccination campaign where we vaccinated twice 20,000 dogs in N'Djamena, the capital city of Chad, in 2012 and 2013. And you see how rabies transmission collapsed after the first campaign already. And here is again the economics. If you only treat humans with post-exposure prophylaxis, you have that increasing line here. However, if you mass vaccinate dogs and they do not reinfect again from outside of the area, you have higher cost at the beginning. But because you interrupt transmission, the curve flattens. And over a 10-year time period, the intervention in dogs is less costly than the intervention in humans. Currently, we did a game theoretical analysis that comes to the same conclusion as I present here. Now, the World Bank has already in 2012 proposed this red-green schematic that you see here on the down right. And it says, if you detect an emerging virus in the environment or in wildlife or in mosquitoes, the associated costs that are represented by the red line are relatively low. But if you wait until it gets into livestock, the costs increase and the costs become highest if you get into human health. So this has been very nicely demonstrated by the COVID pandemic. So currently, so this would mean that we should really integrate disease surveillance response system worldwide. But currently, human surveillance response systems and animal response systems are separated. So both are ruled under different regulations, the international health regulations and the performance of veterinary services by the World Organization of Animal Health. So our vision is to operationalize One Health under a One Health governance, as we will discuss in the forthcoming papers. And this should actually probably not prevent future pandemics, but reduce the cost massively by communicating between human and animal health in integrated human-animal environment surveillance response systems. Now I hand over to Katrin to give us the evidence of the operationalization. Please, Katrin.
Thank you, Jakob. One Health has been mentioned in GEE and PVS reports across hazard groups. Strong evidence base is established for prevention and preparedness, endemic infections, and AMR. And we found weak evidence for extreme weather, water security, and environmental degradation. More research is needed to show incremental benefit of One Health in food safety and nutrition security. Next slide, please. Let's look at future operationalizations of One Health. At global level, we now have the quadripartite. At national levels, there is a need to expand the horizontal integration and specify who participates and how the multi-sectoral coordination is organized. In terms of funding of One Health operationalizations, this needs to be negotiated across sectors with the potential of cost sharing. Next slide, please. So what are the key messages? There is clear evidence of One Health benefits. However, greater investments in preventive interventions, particularly in environmental and animal health, are needed. Second, One Health has a high potential to improve global health security. For resource-poor settings, we recommend that investments should prioritize endemic One Health issues where the evidence base is most strongly established. Thirdly, there are knowledge and implementation gaps in environmental, wildlife, agricultural, and farming issues. So One Health approaches should integrate these issues more fully to better address pandemic threats. There is also clear evidence of increased levels of compliance with IHR across the globe, though an evidence-led acceleration of implementation and expansion of integrated approaches across a wider spectrum of hazards are needed. Lastly, further research is needed. Studies should include analyses of trade-offs and co-benefits, cost-effectiveness, comparisons of uni versus multi-sectoral approaches. Thank you very much for your attention.
Fantastic. Thank you so much, both of you. Keep your questions coming. We're going to have a Q&A session at the end. Now let's move on to paper 2, which is a global analysis of One Health networks and the proliferation of One Health collaborations. And I'm very pleased to introduce Atman Mwatondo and Afifa Rahman Shepherd. Dr. Mwatondo is a senior medical epidemiologist at the Ministry of Health in Kenya, and he leads the zoonotic diseases unit there. And Afifa is a PhD student at the School of Public Health at the National University of Singapore, and she focuses on the regionalizing of pandemic governments and technical capacities. So over to you, please, for paper 2.
Thank you so much, sir, for the kind introduction. My name is Atman Mwatondo, based in Nairobi, Kenya. And my colleague Afifa will join me shortly. So our paper is the second installment in this series, and it looked at the global landscape of One Health approaches and how these approaches, which we call One Health networks, address threats to global health security. So all the definitions of One Health that I've come across, including the newly published definition by the One Health high-level expert panel, underscore the need for multi-sectoral collaboration and partnerships. And therefore, we need to, it underscores this and the need to break barriers between sectors and disciplines. And we know that how One Health is operationalized and its process influences the nature and extent of cooperation between stakeholders. And this is on important issues that include investments and prioritization of areas of response. So we know the need for partnership, but what constitutes a good partnership? I think that's a question that we're asking ourselves. And with the COVID-19 pandemic, we know there's a renewed focus on One Health now. And we may see in the near future many more networks being formed. So it's important that we monitor the development of these networks so that most of them align to the current needs. So our aims were threefold. The first was to identify One Health networks, which we'll define in the next slide, and support efforts to develop a worldwide repository of networks and initiatives. And this is something that's going on by many partners. And the second was to highlight the areas of focus and alignment with global health security. And this is important because right from paper one, where the evidence was clear on where the most focus should be, we sought to find out whether this is actually happening on the ground. And the third was to identify gaps in One Health formation from a needs-based approach. And from here, come up with recommendation to strengthen future collaborations. So on our methods, we defined a One Health network as an engagement between two discrete or distinct organizations or entities with representation from at least two sectors. And these sectors, we know them as human health, animal health, and environmental health, where animal health also includes wildlife, and environmental health can also be called ecosystem health. And this we adapted from work by Professor Michelle Khan and others. We developed a search strategy where we searched three databases, that is PubMed, Google, and Google Scholar, to identify networks between a 15-year period from 2007 to 2022. And we also screened One Health conferences in that same period. We did this search in English, and we used terms such as networks, platforms, consortia, and many more that are in our supplement. And only networks that met this specific case definition were included in our analysis. To complement our analysis, we included four case studies from four diverse case studies to illustrate key successes and challenges in operationalization. And this case study included the Global Alliance for Rabies Control, which is a well-known global network focused on endemic diseases, specifically rabies. And we also had the Human Health for Human, Environment, Animal, and Livelihoods, HEAL, which is a cross-border network between Kenya and Ethiopia with a strong community-led approach. The third one was the Health for Animals and Livelihood Improvement, HALI, which is a network between Tanzania and the United States and bridges the health and livelihoods. The fourth was DANMA, the Integrated Antimicrobial Resistance Monitoring and Research Partnership, which is a well-established network in Denmark operating at the national level. So on our results, so our search resulted in about 22,000. We had 22,000 results. And of these, we removed duplicates and irrelevant results, and we came up with 3,729 potential networks. We applied an eligibility assessment, which made sure that all networks to be included had to meet the strict case definition. And from here, we came up with 184 networks. We collected data from these 184 networks on where the geographical location of these networks, the sector representation of these networks, the funding of these networks, where they headquartered, where they have mission, vision, and all that. So on geographical distribution here, we can see that most networks operate at the national level. So these are mostly country level networks. Or university level networks within a country. And this is followed by global level networks. And global networks here, we mean a network that has operations in two or more continents. And then lastly, regional level. These are mostly continents or subcontinental networks. In sector representation, almost all networks involve the human health sector, but we can see that about 9 in 10 involve the animal health sector, while fewer networks involve the environment sector. I will now pass it over to Afifa. Afifa, please.
Thank you, Athman. So you can see we established a timeline of network emergence from the year 2000, and we observed substantial year-upon-year variation with notable peaks and troughs in the number of networks forming in certain years. So we speculated here that the peaks may be triggered by an outbreak event or an epidemic, such as the Ebola epidemic in 2014, or the launch of a threat-related global initiative. So we do anticipate there being another peak in network formation in the years to come as a result of this pandemic. Next slide, please. We mapped also the geographic distribution of networks, as Athman said, and our key finding here is that the majority of global networks are headquartered in Europe and North America. Europe also has more regional and national networks than other regions. We see this skew in investments as being problematic in terms of equitable power and resource allocation in One Health. And we highlighted the Global Alliance for Rabies Control as one example of a globally focused network that has decentralized its governance structures into 3 regional networks with no formal headquarters. So GARC has a secretariat with a primarily administrative role to coordinate across regions, but technical collaboration and implementation is still primarily country-led. Next slide, please. The analysis of networks' priorities in terms of health security issues indicates very clearly that emerging infections and novel pathogens are the dominant focus, despite our series demonstrating that there is a clear evidence base for a One Health approach to address a wider range of health security threats. We argued that while pathogens of epidemic and pandemic potential justify high resource investment, there is always an opportunity cost involved in competing for and allocating finite resources. Ultimately, this opportunity cost can risk exacerbating vulnerabilities in context with a high burden of other health security hazards of One Health relevance. We highlight here the HEAL project, which Athman said is a regional network operating in the Horn of Africa that applies a One Health approach to security threats affecting pastoral communities. The network is driven by its community needs and provides an example of a network that contextualizes its operations to fit local realities. Next slide, please. So in terms of networks partnership and formation structures, we identified some severe imbalances in the proportion of networks that involve environment or ecosystem stakeholders, community stakeholders, and in establishing accountability structures such as strategies or action plans that have measurable indicators of progress. We highlight here our final 2 case study networks to illustrate how a whole of society approach to One Health can be operationalized in the case of the HALI project to ensure broad buy-in and collaboration across sectors and stakeholders, and how transparent annual reporting of well-defined outputs and deliverables in the case of DANMAP attracts attention from policymakers and industry stakeholders and can lead to more sustainable efforts in One Health implementation. Next slide, please. So to summarize our key messages, our study revealed deficits in the geographical distribution, the focus areas and activities, and the partnership and formation structures of One Health networks. This, we argue, affects the effectiveness and sustainability of One Health efforts to address urgent threats to global health. We observed a concentration of networks in Europe and North America, which we believe reinforces high income hegemony in One Health investment and priority setting, a focus on emerging threats at the expense of other pressing threats relevant to different regions and local contexts, underrepresentation of key stakeholders, limiting the extent to which a multi-sectoral and a multi-stakeholder approach is implemented in reality, and a lack of accountability structures which are necessary to measure and demonstrate impact of One Health networks, both individually as well as collectively. Next slide, please. So to conclude, to make One Health approaches more equitable and more inclusive in addressing global health security issues, we've proposed 4 recommendations. First, to base network formation on appropriate governance arrangements and management strategies between all stakeholders and sectors involved. Second, to ensure country leadership and community ownership of activities and align investments accordingly. Third, to meaningfully engage in local realities and priority setting through greater inclusion of and accountability to those communities. And fourth, to establish a repository of One Health networks, such as ours, to monitor formation and evolution of networks' contributions to global health and health security. So on that note, we'd like to thank all of our co-authors, some of which who I can see in the participant list, the series leads, the Lancet, and today's organizers for the collaborations over the past few years. Thank you.
Fantastic. Now we're really getting into the detail of the challenges that we face if we're going to scale up and roll out this One Health approach. Not really One Health if you don't have a proper inclusion of environment and animal health communities in this. So our paper 3 is going to try and answer the really challenging question of how prepared is the world. And they've tried to identify weaknesses in the existing assessment frameworks for global health security using a One Health approach. And so I'm very grateful to Dr. Tible Traore and Najmul Haidar for presenting this work. Dr. Traore is the technical lead and One Health focal point for WHO Afro, and Dr. Haidar is a lecturer in epidemiology at Keele University, and he's a veterinarian epidemiologist and public health researcher. So over to both of you, please.
Okay, thank you. Thank you, Dr. Richard Otton. Are you going to project it, or I will project it from my side? Hello, can you hear me?
I think you're going to be projecting.
Okay, okay, that's fine. Thank you. Okay, I'm sharing my slide now. Yeah. Oh. Can you see?
We can see, but it's not formatted for the full screen.
Oh, okay.
That's better, that's it.
Okay. Okay, thank you very much, Dr. Richard Otton, and thank you, colleague. I would like to thank all the co-authors. We have 28 co-authors, and thank you for your contribution. So we are pleased to present this to you today. And our study was focused on identify weaknesses, as Professor Richard Otton mentioned. And preparedness is, in fact, very complex. It is a complex system, and you need to address not only the national level issue, but also the community and even individual. And you have seen in the previous presentation how important community and individual are in terms of One Health approach and its benefit. So we try to address this issue by looking at the assessment tool, in particular the joint external evaluation, which is a standard tool to use for the International Health Regulation 2005, the legal framework agreed by member states, and to look at the combination of planning, allocation of resources, even training at a community level. Indeed, following Ebola outbreak in West Africa, you have seen that substantial progress has been made to improve the assessment tool, to develop and improve assessment tool, in particular the joint external evaluation, which is one of the IHR monitoring framework, evaluation framework, and the PVS, performance for veterinary services. And so these tools exist, but how they are used to assess the capacity of country at for preparedness, and we will look at that one, what's missing in those tools and how to improve it so the world can benefit One Health approach in terms of human, planet, and animal, and including wildlife and domestic life. We developed this framework with colleagues, and it is published in the Epidemiological Week for WHO. It is the starting point, And if you look carefully at this, there are elements of community level which probably we can improve on the outcome of this tool by using those elements, the outcome of our analysis. The COVID-19 pandemic, as our director, WHO director, Dr. Tedros, has mentioned clearly, it has shown that the world is not prepared, and it was not, and it will remain unprepared for large pandemic like COVID-19, which to better support member states, really to be well prepared, we need assessment tool which will go beyond the national level and to address community issue, individual issue at all, and so that we can gain trust and the world can benefit. I will move to for that reason, we had the following objective: to identify and review the global assessment tool, mainly the joint external evaluation, and to propose a systematic evaluation approach to improve the interrelationship and the engagement of local community and individual to address the One Health issue. To do that, we conducted literature review and qualitative analysis in case study, and this case study, Dr. Najmul Aida will talk about the case study too, which is to look at the GA and the global health index to the death caused by COVID-19. You will see that one. And we had the panel one as well. In the panel one, the study conducted in Nigeria and Pakistan, Ethiopia, and to look at the GA and even at the subnational level, how this could be taken into account to improve and to generate as well inductive insight by identifying existing narrative and idea from observation that we, rather than a systematic review or meta-analysis for indicator. We will focus on, we focus most on the joint external evaluation because that's the only capacity assessment tool linked and grounded in the international legal agreement and primary tool for the IHR monitoring and evaluation framework. The common use tool, if you can see them, here on the right, for example, you can see the different assessment tool, and including the joint external evaluation, the tripartite zoonose guide, and even the UN Sendai framework for disaster reduction. All these are tools used to assess country capacities, and new tools being developed as well. They will complement each other certainly, but looking at the circle, the various circle here, if you look carefully, you will see that at the animal and environmental level and human level, you have really overlapping factor, contextual factor. If preparedness is really something to achieve, really we need to look at the interaction of all these elements. And it can be done because we have done similar work to harmonize, for example, the international health regulation and performance for veterinary services, the joint work to harmonize the tool, it bring really innovative approach, taking that to the community level.
2 minutes, please, then we have to wrap up.
I leave
2 minutes.
For Ada, I leave for you here, please. Continue.
Okay, thank you. I have to finish in 2 minutes. So the key finding is that there is a little consideration of a macroeconomic and societal factor has been given, especially on the food security, trade, migration, climate change, and multi-sectoral governance. In any aspect, in any technical assessment tool, these aspects should not be ignored. Then in one of the case studies, we found that from Nigeria, we found that assessing subnational capacities with national tool is a problematic issues. Key health issues that was not captured should include global context and the structural influence, food and nutritional insecurities, community empowerment, and health inequities. Next slide, please. Next slide. So we compared 2 pandemic preparedness index, including Global Health Security Index, prepared by Johns Hopkins University, and Joint External Evaluation, JEE, prepared by Health of WHO. And we compared how country has responded at the first phase of the pandemic, that is the first year, until 31st December 2020. And you can see from the graph in the bottom that both index has a kind of similar agreement, like they have a very high correlation. When we compared countries' mortality rate in terms of deaths per million population, we have seen that they have a moderate population, indicating that countries with a higher score had higher mortality, which is kind of unexpected. We expected that countries with higher preparedness would expect lower mortality rate per million population. Similar is the case for the cases per million population. Next slide, please.
Okay. Can you go to your concluding comments now, please?
So in conclusion, we would like to say, Tabla, you can conclude here.
Yeah, hello. Thank you, Najib.
Please.
Yeah, the concluding existing tool and indicator framework should be reviewed. And that's our conclusion. And there is a need to rationalize and harmonize the plethora of existing framework. It can be done. We have done that in National Bridging Workshop, and which were mentioned. And agency and country should really have the ability to identify and select hazards that are relevant to country, as it was mentioned in the first paper. Monitoring and evaluation should assess both outcome, health cost benefit, and trade-off, and risk factor for emergency. Without doing that, we will pass by. Thank you very much for your attention.
Thank you very much indeed. Let's move on to the final paper before the question and answer session. The final paper is on governance, global and regional governance of One Health, and the implications, again, for global health security. And it's a pleasure to welcome Azza Al-Nayem and Ola Mohammed Ahmed. Dr. Mohammed Ahmed is a consultant in global health at the UK Health Security Agency. Welcome. And Dr. Al-Nayem is a specialty registrar in public health at the Royal Free London NHS Foundation Trust, which happens to be 5 minutes walk from where I'm sitting. So it's a great pleasure to welcome both of you. Please take us into paper 4.
Thank you for that introduction, Richard. And on behalf of our other 20 co-authors who are here today, we're here to present paper 4 of the series, which is Global and Regional Governance of One Health and its Implications on Global Health Security. So just to quickly set the background and build on what our colleagues have said today. Firstly, I'd just like to point out that there is a range of governance mechanisms on offer at the global and regional level, and these vary on a spectrum of bindingness. We have hard binding tools, which are legal tools that steer with compliance and accountability mechanisms, to more soft instruments such as normative and technical guidance and diffusion of information. And the global governance architecture that delivers these mechanisms is not only constantly evolving. I know we've mentioned OLAT earlier today, but also the quadripartite between UNEP, the WHO, WO, and FAO. But also this architecture is incredibly complex. If we look at this figure here, which was from Dashik et al.'s paper in 2000 in Science on emerging infectious diseases of wildlife, for zoonoses alone, we can see that the proximal determinants of emerging infectious disease sit across a range of systems, whether socio-ecological or ecological in the sense of ecological manipulation, agricultural and extractive industries, technology, trade, and industry. So if this is what it's like for emerging infectious diseases alone, when we expand that One Health approach to factor in things like climate change, food security, water security, and land use and land change, the governance mechanisms on offer change and expand as well. So the objective of this paper was not necessarily to map out the global architecture, but to really analyze the challenges and opportunities that the current governance mechanisms we have for One Health approaches are like. To give you a brief idea of our methodology, we won't go too in depth. We took a grounded theory approach, first by using a literature review to identify hard governance mechanisms, so namely those legal instruments that impact the delivery of a One Health approach linked to human, animal, plant, environmental health, and trade. And we undertook a content analysis of these 25 legal instruments using Sebastian Oberthur's 2019 stringency assessment framework. We then supplemented this with 3 case study analyses to sort of highlight the wicked problems of governance mechanisms at global and regional level, and supported this analysis with expert opinion consultation. And these are the case studies. Apologies, we cannot go through all of them today for time, but we'll try and focus on 2, so the ones highlighted in the boxes above. And from these 2 case studies, we hope that you can see the 4 challenges, really the themes that we've picked out from our analysis. Firstly, the siloing of disciplines in One Health governance, even at a high level, the complexity and contradictions of the international legal system and priority setting in big multilateral system and fora, and the ongoing challenges of underinvestment, which is a tale as old as time in global health. I'll start off by introducing the case study on access to medicine. So this is not a new global health issue, but it will remain critical with regards to One Health approaches. This is not just necessarily about equity in the distribution of these products in a pandemic, but rather our ability to deliver rapid support outside of emergencies, sharing technical resources across animal, human, and plant health, and regional capacity building for the Global South in business as usual activities. These issues are largely underpinned by a legal instrument known as TRIPS, so the Agreement on Trade-Related Aspects of Intellectual Property Rights, which I'm sure some of you are familiar with already. But really, I want to talk about how COVID-19 has offered us a critical window to reshape the intellectual property rights system that governs these processes and to reshape TRIPS. We've seen policy shifts on provisions such as the underutilized compulsory licensing provision of TRIPS. And the US, who traditionally opposed compulsory licensing, gave some limited initial support to India and South Africa's proposal at the WTO to waive TRIPS provisions. And it shows us here that pandemics can allow us first to re-examine the status quo, and second, to rapidly improve critical health literacy for One Health approaches. However, the intractability of this governance mechanism remains due to the ongoing imbalance of power and commercial interests. We've seen that TRIPS proposal get watered down despite great support from 65 co-sponsors and high-level talks of, addressing inequalities. So the law itself can only progress so much on these issues before its role in a wider system can become an obstacle in itself. And I'd just like to draw your attention here to a Suarez and Aubrey quote back in 2014, which is still pretty salient today. This was a reflection on the utility of soft law instruments, and at the time they were looking at the voluntary guidelines on the right to food. And they point out here that governance is a highly contested fluid game, and it is determined more by power politics than by law. And what I really think they try to emphasize with this is that positions of power and strong state-centric security policy will consistently triumph over notions of shared ideals and the global public good in law, unless we see traction in sort of the level of high-playing power political players. So the challenges of legal instruments, as from our analysis, are really that non-health legal instruments are more powerful and effectuate results in their spheres more successfully than health-related legal instruments. And this is a finding in line with works by other academics and practitioners such as Hoffman. However, work can be done to support this and, for lack of a better phrase, play the game. Firstly, the idea of opportunism and forum shopping, in particular for low and middle income countries, comes to play in the process of a potential new pandemic treaty on the horizon, but things that may take a long time to bring back together. So a good example of this is Indonesia's claim of viral sovereignty back in 2005, where they used the Convention of Biological Diversity to their favor. This is a treaty that one wouldn't normally consider health related, but actually was a really useful one to counter perceived exploitation in the access to medicine space. So this first solution really needs to be supported by our second point here, which is that we need to upskill the legal expertise of One Health practitioners, whether that's using environmental law, trade law, impact assessment law. This may secure wins where health law fails. And this should be supported by knowledge sharing and actual uptake of resources that exist, but people may not know about, for example, the HIDE database. And lastly, regional capacity building can promote regional governance at a much stronger level, perhaps in the global scale, because we've removed potentially destabilizing members, although it's still at risk of that, of course. A good example of this is Africa Medicines Agency's new treaty on a regional regulator for medicines in Africa. So not only will this promote self-sufficiency of technical resources and create a sustainable market for these products, but it will strengthen bargaining power in an IP global system that has shown quite entrenched resistance to change. So that's kind of a quick summary of this first case study. I'll hand over to Ella now to do our second.
Thank you. So our next case study considers an example of a regional health crisis within a global health crisis, and that is the impact of the desert locust infestation on food security during the height of the COVID-19 pandemic. So for some context, extraordinarily wet weather events as a result of multiple cyclones in the Indian Ocean over 2018 and 2019 resulted in vegetation growing in the usually dry and arid parts of the Arabian Desert and Africa. This allowed back-to-back locust swarms to form and breed, then migrate across Southwestern Asia and East Africa, destroying large expanses of pasture and cropland over the next few years. Bearing in mind that a single 1 kilometer swarm can consume crops that would feed 35,000 people, the severity of this infestation resulted in an acute food insecurity crisis for an estimated 25 million people across multiple countries in Asia and Africa. As it occurred during the peak of the COVID-19 pandemic, this meant real challenges in securing the agricultural labor, the pesticide products, and emergency food supplies required to adequately respond. As illustrated by the locust crisis infestation, there are serious threats that can cross borders, impact on health and food security across regions, and yet garner little interest or attention in global policy and financing. The cost of recovery from the locust infestation is estimated at 8.5 billion. And while this is much smaller than estimates of the cost of COVID-19 recovery, which are generally in the trillions, little funding has actually been secured towards the response and recovery to this infestation. Importantly, this case study highlights the unpredictable and destructive impacts of climate change, particularly on vulnerable communities. And it also highlights the realities of climate injustice, given that the majority of the affected people have contributed very little to historical emissions. So what does this mean for the global community, and are there any solutions? Over the past decade, there have been a number of financing mechanisms, including insurance-based mechanisms through the World Bank's Pandemic Emergency Financing Facility, or the PEF, and the African Union's African Risk Capacity. These have offered promise in terms of addressing one of the main challenges in global financing for emergencies, which is often donor fatigue. However, the real challenge in managing insurance-based schemes is how they agree disbursements. For the PEF, this is based on commercially sensitive agreements with private investors, but both mechanisms have failed to rapidly respond to crises and need to involve civil society. We also consider that there needs to be greater investment in prevention, preparedness, recovery, and resilience. This has been shown time and time again, including the Ebola virus outbreak of 2014-2015, when the underinvestment in health systems came with a devastating cost to human life. Spending on prevention and preparedness is associated with a high cost-benefit ratio, and there have been a number of instruments from the World Bank in recognition of this, including the more recent Financial Intermediary Fund. These instruments must be inclusive to low and middle income countries and civil society, and flexible enough to prioritize their needs. So we'd like to leave you with three of the key messages from our analysis. Firstly, the global governance of One Health must move beyond zoonoses and infectious diseases to consider other health emergencies, particularly those of concern to communities. This means a better understanding of the underlying social, political, ecological, and economic drivers of those issues, as illustrated in our case studies. Secondly, the legal frameworks that support One Health approaches are less robustly applied and enforced than their counterparts in international trade and finance. In order to address this, there is opportunity to leverage existing provisions within non-health treaties to achieve a positive impact on health. Again, this highlights the need for One Health to bring in legal expertise, social scientists, economists, environmental experts, and of course, communities and civil society to strengthen the approach as a whole. And lastly, recognizing the real resource challenges that exist for small states and low and middle income countries, we have seen that building capacity across countries at the regional level can be a way to pool resources and expertise. It can also be a way to gain political and financial power to promote their interests on the global stage and address some of the inequalities that threaten our collective health security. Importantly, those regional organizations can act as transformative vehicles for the implementation of international norms and laws, whilst also introducing locally sensitive and flexible options for governance. So thank you very much for listening, and we welcome any questions through the Q&A and by email. Thank you.
Brilliant, brilliant final paper. Thank you so much, and absolutely superbly presented. Love your point about the legal frameworks. A few years ago, we published a commission from the O'Neill Institute at Georgetown University, led by Larry Gostin and others, really emphasizing the fact that we don't pay as much attention as we should to on about legal instruments and legal determinants of health. And on the regional focus, interesting, just reading a book from the Council of Foreign Relations recently that was arguing we've misunderstood the past 20 years. It's not been an era of globalization at all. It's actually been an era of regionalization. And we should be looking to strengthen regional networks rather than just simply thinking about global networks. And that your evidence and arguments chime perfectly with that view. Right, so now it's a chance to have a discussion. So can everybody turn on their cameras so that we can see everybody magically? And I've got a whole series of questions. We've got about 13 minutes or so of question time. So I'm not going to direct them to any one person in particular. So please, perhaps you could put your hands up using the hands up function, and then I can come to you for an answer. And the first question is a really interesting one. This is a series about One Health and global health security. And a question from Bay Wessie is, how do we actually measure the contributions of One Health in global health security? How can we quantify the contribution of One Health to global health security? And if we could do so, I imagine, then that also strengthens the argument for One Health. Who'd like to try and answer that? I'm looking for hands up. Otherwise, I will go to one of you if I don't get a hands up within 5 or 10 seconds. Jakob, great.
Can you activate my microphone? Ideally, you can measure it by looking at what kind of platforms are institutionalized. I give you one example. The country of Chad has just institutionalized a platform of One Health under the leadership of the Prime Minister. And this is a hard evidence of the willingness of a government to engage in integrated approaches. To be clear, we don't need new ministries, but the existing ministries must better cooperate. And many countries go in that direction. Thank you.
That's great. Yeah, that's very helpful. Anybody else want to chip in? Okay, yes, Osmond, go on.
I was just going to say, Richard, I think that's a really good question, and from our perspective, from public health as well as a One Health perspective, it's about setting a framework, appropriate framework for making those measurements, right? And what we've tried to do through OLAP as well as the series, the One Health High-Level Expert Panel, as well as the series, is that they need to be the right kinds of measures for both assessing outcomes as well as the process of delivery. So around outcomes, it's not simply enough to just look at health outcomes in the human health sector. You have to look at outcomes across the 3 sectors to make sure that everyone's interests are being met. So human health outcomes, animal health related outcomes, as well as ecological outcomes, and to assess also the trade-offs within interventions. Often there are interventions that are put in place which where there's a negative externality to the animal health sector or to the ecosystem side of it. So measuring those trade-offs is important. And then finally, in terms of the process, One Health as a framework has underlying principles around equity, around inclusiveness and parity, around setting an ecological equilibrium, stewardship, as well as transdisciplinarity. And all those are processes which have defined measures that can be included in any form of evaluation.
Very good. Tible. If you just, yeah.
Okay, thank you very much, Richard, for this. And yeah, this is a great question. And I can just give you an example how one can measure the benefit of One Health approach. We have proposed with Professor Briggs Wilcoxon, and that was to address vector-borne disease and environmental health. And the outcome we propose to be measured is the well-being. And the well-being is measured not only by the absence of disease, and you have all the psychological and all the factor into it. And again, you can add to that one the probability and of low risk, and you can even go beyond, and the generation of new knowledge and community development. All these can be factored into it. But to do that, really you need to have a good operational setting for that one. And that, again, you need to have different element, component, which need to be taken into account, organizational level, capacity building, and again, you go back for the risk. Then it is a logical framework which can be used to support the One Health operationalization and the benefit assessment at community level, individual level, and so that has been demonstrated to work well in vector-borne disease and environmental health. And the same can be taken as socio-ecological framework application. Thank you.
Excellent. Thank you very much. And I'll take one more comment before we move to the second question from Afifa.
Thanks, Richard. I'll make this quick. I think this measuring effectiveness, I saw the questions and it was beyond the scope of our paper, but I think there are 3 points to highlight. One is there was formerly the Network for Evaluation of One Health, which has now been incorporated into the European chapter, I believe, for One Health, and it's called the Network for Eco-Health and One Health, but they're worth checking out their toolkits for measuring One Health activities. And then I did want to reiterate the variation that we found amongst One Health networks in terms of self-reporting their own indicators of progress and making that transparently available for external scrutiny. So I think there's sort of a call for networks to also publish if they have and establish if they haven't. And then just also from our paper as well, paper 2, that we identified sort of the software of One Health networks in terms of partnership structures, which I think should also start to be incorporated into how we measure the effectiveness of One Health networks. Thank you.
Thanks, Afifa. That's lovely. A second question from Gabriel Parahaneo, and their question is a challenging one because it's easy to talk about this kind of tripartite collaboration between different communities, health, animal, veterinarian, and environmental. But intersectoral collaboration isn't easy. In fact, it's really quite difficult. And so we've had a few case studies presented in your papers. Would any of you like to comment about how you actually make intersectoral collaboration work in the field? Any clues? And again, I'm looking for hands going up. Tible, you got your hand up.
Yes, thank you, Richard. Yes, my hand is up, and a colleague can complete what I will outline. And first of all, really, it is very interesting to move on for the background, which is to use the existing framework, and which is IHR monitoring evaluation framework, performance for veterinary services. We have done that. Dr. Atman Mwatondo can confirm that one, and Osmond that himself. And once we try to bring the sector together, and it turned out really, they come up with practical solution, how to improve the collaboration. By doing that, they develop a roadmap, joint roadmap, which really need to be implemented in line with the National Health Security Plan. And for such a reason, such an approach can be applied even at the local level to bring intersectoral collaboration. And we have seen that with paper published by Syntax and colleague as well. And it really improve collaboration. But they need to have that stakeholder meeting. And that stakeholder meeting, really, it's not just mapping, but it needs to be stakeholder meeting and stake analysis as well. The benefit from farmer, local producer, and local institution, government, and everyone needs to know their role. Primary stakeholder, secondary stakeholder, you can add a tertiary. They need to discuss, and they need to align their perspective. Okay, thank you.
Excellent, very helpful, practical points. Jakob.
Yeah, I give you a very practical example. Within the Chichiga University One Health Initiative in Eastern Ethiopia, we have established an integrated surveillance response system at the district level. But we went through a participatory transdisciplinary process where all the actors told us from their practical experience how they would implement it. So by carefully listening to communities and local actors, authorities, we can find solutions that we could never invent from an academic desk. For example, we started working with community health workers and community animal health workers, and they call the surveillance system. And since these people live in the village together, they started to become friends. So the village animal health worker and the village public health worker start working better together. And this is at the root of a better One Health collaboration that can scale up to whatever you want. But if we can start in the villages, then we have a huge potential of leverage. Thank you very much.
Excellent, thank you. Allah.
Yeah, I wanted to just add a perspective around some of the national governance arrangements that facilitate that kind of coordination. I think that it's around making sure that the institutional architecture helps to support that collaboration, particularly between ministries, where often there isn't necessarily a clear pathway to communicating or pulling resources between the various ministries that have a role in One Health. I also think that while we focused mostly on the kind of global legal instruments, there is a way for countries to use those global legal frameworks to introduce their own domestic laws, or where they have ratified that agreement to then use that directly rather than introduce their own domestic laws for countries that are able to do that. So I think it's there is a perspective around how from a national level it's important to facilitate that environment that allows that collaboration. The other thing I would just add is that around what we often find is that there is a challenge in actually communicating and collaborating between professionals because they have such different perspectives on and paradigms around what health actually means. So I think from a kind of workforce planning perspective, there needs to be that increasing integration between the various professional groups that have an interest in One Health. So shared curricula and so on, and opportunities to collaborate throughout their professional life. So yeah.
That's great. Thank you very much, Ola. And then I'm going to give a last comment because we have to draw this part of this session to a close, to Atman.
Yeah, thank you so much. So how do you make collaboration work at the lower level? So I work at the country level One Health platform. And I think we've seen the talk shop at the top level. We are always talking, coming up with policies and strategies, but then the real work is in the lower levels. And therefore, I think there's need to prioritize with the lower level teams. Once you focus on their priority, normally it becomes very easy to collaborate with them. Unfortunately, a lot of times we focus a lot on the emerging things. I think COVID is one of them. So we went to lower level to talk about COVID. We didn't realize why it's important, yet they have rabies and brucellosis, which we are not interested in. So I think for me, the best way to tackle this is to do genuine prioritization with the lowest level people. And I think with that, you will get through to them and they will understand each other, they know each other, they'll work easily together. Thank you.
That's fantastic. Thank you. I'm going to thank all of our presenters, and I apologize to the excellent questions and questioners that have given these questions because we've not been able to get to them all. But there is a second part to this discussion. And so we're going to take a 5-minute break and then we're going to return. And I hope that you will all continue to join with us. And please give a round of virtual applause to all of our excellent presenters for the work that they've done. Well done. See you in a few minutes. Okay, I think we're ready to... Okay, I think we're ready to begin again, and welcome to the second part of this event. I hope you're able to catch the presentations of the 4 papers that made up the Lancet series, because that provides a very good basis for the discussion you're now going to hear. You've heard far too much of me in the first part, and so I'm immediately going to hand over to my brilliant colleague, Francine Ntumi, who is the founder, the chair, and the executive director of the Congolese Foundation for Medical Research and coordinator of the Pandora-ID network. Francine, it's great to see you, and I'm going to let you take the stage to introduce some of our wonderful presenters for the discussion this afternoon.
Thank you very much, Richard, and good afternoon, everyone. I'm really delighted to be here today and happy to help chair such an important discussion. So first up, on our panel, we will have Professor Richard Koch. Richard is a professor at the Royal Veterinary College, and he's a senior consulting fellow for the Global Health Program at Chatham House. And second, we will listen to Professor David Heyman. David is Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine, and head of the Centre of Global Health Security at Chatham House, London. And I'm happy because both are key partners in Pandora Network. And third, we have Dr. Catherine Mashalaba. Catherine is the principal scientist for health and policy at the Conservation and Global Health Organization, EcoHealth Alliance. So now I'll hand over to Richard to introduce our 3 other panelists.
Thanks, Francine. Lovely. Well, my 3, it's a great pleasure to introduce a very good friend, Dr. Maria Neira, who many of you will know is the director of the Department of Environment, Climate Change and Health at WHO. And she and her team really have done an absolutely incredible job at getting these issues higher on WHO's agenda. And Maria deserves a particular tribute, I think, for her persistence and tenacity over recent years. Second, let me introduce Dr. Chadia Wanu, who is the One Health Global Coordinator and Senior Specialist for the World Organization for Animal Health, otherwise known as WOA, which is a great name. So welcome to Chadia. And then third, let me introduce Dr. Chaduddin Raji, who is the head of the Public Health Institutes and Research at Africa CDC. And Africa CDC is a really, really critical organization for us and one of the most important institutional innovations in recent years. And great to have Dr. Raji with us. But before we ask some questions of our panel, I want to ask you, Francine, because I'm keen to hear your perspective. Do you think we're making progress on One Health?
Thank you, Richard, for asking me this question. As the coordinator of Pandora, which is a One Health Pan-African network, I've seen many progresses in building research capacity and technical capability. And here I would like to acknowledge first the contribution and leadership of Professor Sir Ali Zumla at UCL, who is the co-leader of Pandora. And because altogether we have used strengths of European and African institutions for bringing developing institutions in Africa to a higher level. And using this strategy since 2018, we have been able to contribute in response to and research on Ebola, chikungunya, dengue, Lassa fever outbreaks. So, and this difficult situation have been opportunities for building local capacities, for advocating for more local support, and for South-South and North-South and South-North, you understand, both way transfer of technology. And we have seen also African leadership rising. So I really think that research under travel restriction due to COVID-19 pandemic has been supported by an increased data and protocol sharing. And it has been, I have to acknowledge that for Pandora, it has been a wonderful experience of knowledge sharing between the 24 partner institutions. So yeah, so I have seen some progress, but everything is not so positive, and I'm sure we'll come back to that later. So I give you the floor.
No, you carry on with your questions, Francine. That's great.
Okay, so my friend Richard Kopp. So you've spent a career working in wildlife and on ecosystem health. What single lesson would you want policymakers and your colleagues across domesticated animal health systems and human health to take away from today? Richard.
Thank you very much, Francine, and I'll try and be brief on, and it's a single thing. I would like to give you 20, but yeah, I think the key issue coming out of all the papers really is that we need to globalize the community to bring in the perspectives really of the problems rather than the perceptions of people in very developed and advanced economies, because a lot of the wildlife issues are generated by fear. You know, we humans have this natural fear about nature, like darkness, etc. And so we get worried about wildlife and what it can bring. That's evolution. Pathogens come from somewhere. But what's important to me is that the One Health program, if it's allowed to be not driven by, if you like, the power centers, but driven from the grassroots, driven from people's problems. And it was nice, that some of the papers brought this out. We need to ask the people on the ground, what are your problems, and then build from that. And then ensure that the health hierarchies and the knowledge base for solving those problems develops. So to me, that's, it's not top down, it's bottom up. And that's something that I think I've learned. And we need to break down the hierarchies. A wildlife health person has capacity as much as a veterinarian has a capacity as a human health person, but there remain hierarchies which can be quite challenging. Thanks.
Thank you, Richard, and for making on top a people problem, and that's very critical. And so David, so given that you have been at the center of many global decision-making for global health security over the years, perhaps share with us some of your experiences on how equity has improved or worsened, as the case might be in the global health security space, and what do countries have to do to get improved equitable access to tools, technologies, and skills across the One Health spectrum of issues?
Thanks very much, Francine. It's really a pleasure to be working with you in Pandora. And also, I'd just like to start by thanking Osmond for having herded all the cats together to get this launch going and the articles published. Francine, we've seen glimpses of how equity can be accomplished in the past. And most of those have been underlined by advocacy from civil society and also by political will, which is generated through resolutions at the World Health Organization. We saw the eradication of smallpox, a partnership which guaranteed equity in vaccine, smallpox vaccine, around the world in a period when there was great political tension between the USSR and the US, and they were both partners in a program which was successful. We saw the same thing happen in river blindness when together a partnership was formed with industry, this time and other partners, NGOs, which provided ivermectin to countries in the basin of the river where there was river blindness and got rid of river blindness. We saw rinderpest eradication in the agricultural community, very similar to what happened with smallpox eradication. And we see polio eradication today. Equitable distribution of vaccine to all those at risk and in need. These have all been targeted and vertical programs. They haven't been programs that continued afterwards in maintaining access, but they're good glimpses. But the present thinking goes back to 2000, when the WHO Commission on Macroeconomics and Health actually showed with evidence that good health needed to be at the center of rapid economic development. That spun off Gavi, that spun off the Global Fund, both under Brundtland at WHO. And then in 2007, there was a real advance in equity. And that was when the Minister of Health in Indonesia withheld virus specimens from the WHO network that was collecting influenza virus specimens in order to gain equitable access to benefits. And that's become a mantra today. Equitable giving and equitable receiving. And so that resulted in intergovernmental meetings which set up the pandemic influenza preparedness framework, which provides for vaccines during a pandemic and in also medications during a pandemic through WHO, another glimpse of what's possible in equitable access. And then we've seen the COVAX facility and the ACT Accelerator, again, taking that a step further. Now our hopes have to lie in the WHO treaty, which we hope will ensure that there's not only equitable access during pandemics, but also in preparedness. So thanks very much, Francine, for having asked me that question.
Thank you, David. So I can listen to you, all the afternoon. So you are a source of inspiration, all of you, by the way. So you insisted on equitable giving, equitable receiving, equitable access, and the future WHO treaty. So that's, maybe some people will ask, the participant will ask questions. To Maria. Maria, in your role, in your role as Director of Environment, Climate Change and Health at the WHO, this must sometimes seem like too big an issue, too nebulous to be dealt with by many of your specialist colleagues in human health. So how do you communicate the direct relevance of your work and get support for the prevention-focused agenda that is central to it? And around what critical issues would you like to see more collaboration between environmental science, animal health, and human health practitioners? Maria.
Merci beaucoup, Francine. Thank you all very much, Richard. A pleasure to see you again. And thanks all who put this together. It's such a fantastic and an inspiring initiative. And you know, Francine, I am one of those who benefited of the pleasure of listening to David Heyman for the whole afternoon, because for many years he has been my boss. He has my first boss in WHO, and anytime I have the opportunity to thank you, David, I will do it. So I've been benefited from that privilege for a while. Francine, somebody told me very recently, I think he was the Director General of Development in Germany. We were together on a panel, and he told me after the speech we have together, he says, Maria, there is no glory on prevention. And it's true. I mean, there is no glory on prevention. There is no glory. The world has removed lead from gasoline, and probably we have been contributing to a better intellectual development of our society, but there is no glory on that. Nobody will remember the fact that we remove asbestos, or we'll remove many chemicals, or the water is not anymore contaminated thanks to several. There is no glory on that. And maybe it's because our narrative, our communication is not good enough. So this is one part. So clearly we need to, maybe not glory, but definitely some rewarding, positive communication around the fact that what we are trying to achieve here is about primary prevention, and primary prevention remains still one of the best, most cost-effective, public health-oriented, basic interventions that we all need to put in place. When you look at the definition of One Health, the part that I like it the most, and I'm not quoting it exactly, but is that it refers to the optimization of global health. So it means that it's an incredible opportunity to look at environmental health, which is one of the orphans, let's be very honest among ourselves, human health and animal health. Now that we have this triangle, that we have this strategic approach, that the world has again focused attention of the pragmatic and logic question of addressing health security, addressing disease control, and addressing sustainability on this strategic way, we cannot miss this opportunity. And so we need to do an effort on communicating something that is difficult to communicate, maybe by starting not to be part of the problem. Let me explain myself. We need to make sure that we communicate about pandemic preparedness treaty, One Health, climate change, environmental health, disease control, emergency preparedness response, with a common voice, a planetary health, a common voice, please. Otherwise, we can be part of this cacophony, maybe thinking that those are different initiatives, are the same. I mean, are the same. If you want to do a pandemic treaty, and Heyman will correct me if I am wrong, you need to look at the connections between environmental health, human health, and animal health. No way to do other way around. And if you want to focus now on tackling the causes of climate change, which is something that, oops, he connected the camera, so maybe he will correct me on what I said. No, huh? Okay. So if we want to be serious about tackling the causes of climate change, it's exactly the same. It's a basic public health approach. Will require access to safe water and sanitation for our healthcare facilities, vector control, epidemiological surveillance, more resilient climate change health facilities, and all will have enormous achievements that can be communicated. So we need to learn, Richard, you are so good on that. We need to learn on communicating what do we mean by being primary prevention and how we get some glory to those who work on primary prevention. Because today we still don't have, David was talking about inequities, we still don't have access to safe water. During the pandemic, we were talking about wash your hands. With which water? Half of the world cannot wash their hands. They don't have soap. We have healthcare facilities without access to electricity. It's a joke. I mean, don't call it healthcare facilities, call it something else, but there is no way we will have a proper pandemic preparedness, disease control, sustainable development, animal health, if we don't go for the basics first on public health and control. So this triangle, the human environment and animal health, is more important than ever. Starting at the community level, sure, but we need to deliver the message from the global level properly as well, avoiding to end up with different initiatives, all of them merging in the same direction. My final point is that David was referring to all of these very successful initiatives. Most of them is true vertical, but sometimes we need to go for vertical and delivering and achieving and all of that. Now, we need to keep in mind that all of those initiatives, the aim was to control a disease. But you can control diseases or prevent diseases by working in other sectors as well, you know? So what I am trying to do on this One Health is bringing this approach to the climate change negotiation at COP. We are all the time using this approach from a health perspective. We are bringing it when we talk on access to clean sources of energy, because that will provide as well a way to stop deforestation, the destruction of our environments, and the prevention of you know, the wild, the trade on a very not respectful way we are doing, very aggressive agricultural practices. So it's the same agenda. We need to get very much, all of us aligned, convinced, and group to have a very good perspective, passing the message very well, and the communities will respond. This is the most cost-effective approach, but we need to communicate it very well and making sure that we go straight and not diverting the agendas on different directions. Over.
Well, thank you very much, Maria. I have understood and liked the importance of the triangle. No glory on prevention, there is glory. And that the disease could be controlled through different angles. So that's very important. Maybe Richard, if you want to introduce Shadia, or you...
Well, let's, of course, let's carry on with some of these questions, because we should give the others a chance to say a few words. Catherine, maybe I could turn to you. We were delighted to have your comment in with the series as a member of WHO's One Health high-level expert panel. And you present in your comment a beautiful theory of change. And I wondered if you could just say a few words about that theory of change and how you hope it might get picked up by funders, policymakers, and so on.
Thank you,
Catherine,
so much. Yeah, thank you for the opportunity, and thanks to all of this series authors and collaborators. This is really important to take this systematic look. I just want to right at the start acknowledge the One Health high-level expert panel, which is 26 expert members advising the quadripartite. So not just WHO. WHO is a crucial partner, but one of four. And just to acknowledge the World Organization for Animal Health, the UN Environment Program, and the Food and Agriculture Organization of the UN. Just to put this into context a bit, the theory of change is really building on the definition, which we saw the visual for, and again, the three main outcomes that we have to keep in mind: healthy humans, of course, but also healthy animals and healthy ecosystems. And this is really needs to be equitable, the way we think about these outcomes. And then also the underlying principles that Osmond mentioned. I think at the core of that, equity is really cross-cutting. So equity across sectors, but also equity when we think about stakeholders and typically marginalized voices and aspects like animal welfare and sustainability, really bringing these in a way consistent with what the Lancet editorial really called ecological equity as one of the key outcomes. And this really relates to the trade-offs and co-benefits that have to be considered more systematically, really built into the process as we make decisions that are related directly to One Health and health outcomes, but also really far upstream in terms of the drivers of ill health and the social determinants. So just want to give a few examples here of what we address in the theory of change. I would state that it's really reinforcing the quadripartite global plan of action, which we'll hear more about, but also taking a broader look, acknowledging that there are other actors that really need to be at the table, contributing in a crucial way to get to these ambitious outcomes and really sustainable development that is inclusive and improving health of humans, animals, and ecosystems. So I think it's really highlighting in our commentary very timely and urgent needs for doing things differently. So just two examples here of looking at the pandemic fund and then also the pandemic instrument, really sort of making sure that we're not leaving out crucial partners from the start. I think there's this great risk of just business as usual, focusing on human health scope and missing these other crucial areas. I think we've seen this happen in the past, and we really have to act differently from the start to get this right. I think maybe Shadia will highlight that more in her remarks. The second is on impact assessment, and we've turned this in the commentary as a One Health impact assessment as what's really needed. We have environmental and social impact assessment, which does not robustly include health impacts. So bringing this together in a more systematic way, again, considering the trade-offs and co-benefit opportunities, but really looking at the problem way more comprehensively, prioritizing where investments are made and what decisions are made based on the potential outcomes. Just to acknowledge some overall challenges that we have to be really wary of and take action against, but power imbalances in global health security, really often at the expense of local health security priorities and what's prioritized even under national One Health coordination platforms. Short-termism, this sort of focus on after the crisis, we take short-term action and then we forget and we move on to the next thing. Working in silos, and then also rivalries. And we're seeing this already with a lot of funding infusion that's sort of focusing on one sector and not creating the bridges or coordination sufficiently. So just to close, I think we all have first an opportunity, but also really a responsibility to do things differently. We need to make sure that future global health security and health security in general investments are really iterative, and that we're monitoring the implementation as we go and the outcomes, and considering again those underlying principles. So it's not just disease prevention, detection, response, but it's really making sure that equity is included across that. And I think that again, we have to acknowledge this is challenging, but it's feasible. It's what we've called the 4 C's: collaboration, coordination, communication, and capacity strengthening. We're already doing that. We have to do that much more, and we have to do it in a different way. And I think that's the key request from the OLEP, what we want to see, and we're here to support that. So thank you for collaboration.
Brilliant, Catherine. Thank you so much. Let me turn to Chadia. Chadia, I believe that the quadripartite, you've recently launched this global One Health joint plan of action. Tell us about that, and tell us why you think it's important and why people should be interested in this and pay attention to it.
Sure. Thank you so much, Richard, and thank you, Osman and colleagues who put the panel together. It's a great pleasure and honor to be with you today. So to answer your question, it's about the joint plan of action for One Health. It's a request from our member countries to the 4 organizations to work together and develop this One Health strategy. And it's backed by our governing bodies, where resolutions were passed, including one in WHO, one in WHA, asking us as organization to develop this strategy. And why it's important? Because building on the One Health definition and how broad it is, and the importance to have this integrated approach between animal, human, and the environment, with the acknowledgement that now we have UNIP on board. Previously, we were 3 organizations only, WHO, FAO, and WHA. And now we have added UNIP as an equal partner. So we have the environmental aspects should be reflected in our work in the One Health. And we did this development through participatory approach, where all of us have drafting teams contributing to the joint plan of action, but also we had consultation with our member countries and our stakeholders and partners. And importantly, our One Health expert panel, they also provided inputs and guidance into this. So this plan, it's a framework for action. It's a proposal for set of activities that the 4 organizations can offer together to advance and sustainably scale up One Health approach at all levels, including at the national level. So we should support our member countries to turn this approach into actions on the ground. And we have been working on the One Health since 2000 at least. So we have to build on existing initiatives, on existing plans and platforms, not to start from scratch. And importantly, we have to highlight this linkages between the three sectors: the animal health, the human, and the environment. And what does it mean? And to get to your question also about how this series of the Lancet important for us, because we were asked to give the evidence, how to demonstrate that the One Health approach is feasible, is achievable at these different levels, and it's sustainable. And is it cost effective to do this together? And by providing us with these three studies that the author just presented to us, you helped us to articulate some of the issues that we are dealing with. And I just give you an example from the network study. You said that these networks exist, but they are biased regionally wise where they are situated, and they are biased towards emerging zoonotic disease, while the other 6 action or other 5 action tracks of the Joint Plan of Action, including AMR, including the environment integration into well health, including neglected zoonotic disease or vector-borne disease that are important in many countries, and also about One Health capacities in all of these 3 sectors. So this network, they don't address all of this comprehensive One Health approach. The other example I will give you about the tools. Paper highlighted the GIA, and which builds on the IHR in the human health and the BVS in the animal health. We still don't have the environment assessment tool. So this is missing from our existing tools. And currently, our One Health high-level expert panel, they are doing a review of the One Health tools and helping us to identify the gaps and whether there is a need for new tools. The last one, it's about governance. The paper on governance presented by Ola and Azza. It's very important to acknowledge the regional governance. And for that, we are supporting our quadripartite organization to establish regional coordination mechanisms between the 4 organizations, but also supporting countries to strengthen the One Health platform where it exists, or to help them to set it up where it doesn't. But the One Health platform, it's not just to bring the framework. And we could use this soft laws or voluntary guidance, but we need to embed this in the new pandemic instrument. And we are doing a lot of advocacy to get the One Health approach into this instrument, and the focus on primary prevention that Maria highlighted. Because if we don't address the drivers of the risk, we will keep on doing the same, preparing to respond and having more outbreaks and increased severity of outbreaks and shortening the time between them. So we need to break this cycle and work on the drivers, on climate change, on land use change, on biodiversity loss. But to do this, we have to reach out to other sectors that beyond the health sectors and even beyond our quadripartite to the other partners. And the last one about the finance, and Catherine alluded to that the pandemic fund should also have strong focus on One Health and on prevention. Currently, we are not yet member of this governance of the pandemic fund. Neither the World Organization for Animal Health and neither UNEP, the UN environmental programs. So we are in the process of more advocacy should be done, and this series that you highlighted and presented to us provide us also with the evidence that could support this argument. and we look forward to continue to working with you. Thank you very much, Richard.
That's fantastic. That's very troubling that One Health isn't represented in the governance of the pandemic fund. And there's an immediate point of advocacy for all of us to make sure that the fund does take One Health more seriously. This is one of the problems. One Health is often mentioned in many places and many fora, but only lip service is paid to it. So we need to convert lip service into proper action. I saw that actually in a draft. I saw a draft just this week of a G7 health statement that is coming from the Japanese government. One Health is littered throughout the draft, which is great, but there's no actual concrete actions that are recommended. Lots of, the way I put it in response to them was lots of should statements. The G7 should do this, should do that, but no will statements. The G7 will do this or will do that. So we need to convert the shoulds to the wills. Let's turn to Taj, Africa CDC. I mean, honestly, I think everybody's been so impressed with the launch of Africa CDC. We all recognize the leadership role of the organization. Tell us a little bit about Africa CDC and its role in the One Health context. Over to you. Taj, over to you. Can you hear? Please go ahead.
Hello, Richard. Sorry, I didn't catch your question. I would appreciate if you can repeat that.
I was just heaping praise on you and the Africa CDC, and saying how I was love bombing you. And what I would like you to do is to tell us a little bit about Africa CDC and your take on One Health. Whoops. I think we might have a network connection issue here, folks. I'm just going to speak in the ether to our wonderful collaborators who are making this webinar happen to see if there's... Oh, there you're back. I can see you're moving.
Yes. No, apologies. I'm actually in Abuja on the field mission here. So I had to jump into the AU office here to join you. So now, thank you. No, thank you. Thank you for the opportunity to be part of this Lancet series on One Health and health security. So I think for me, just a couple of reflections on the importance of locally and regionally tailored approaches to health security on one hand. This is the whole essence of setting up the Africa CDC by our head of state and government, back then in 2003. And of course, using One Health approach as far as security is concerned, of course, the reason is quite obvious. Today, we know that more than 75% of our
Uh-oh. He'll come back. I know it.
Hello, can you hear me?
Yes, you came back.
Okay. The second thing I also want to emphasize is on the idea or the issue of regional public health emergency or regional approach to our outbreak in terms of declaring health emergency of international concern. So again, this is something that generated a lot of interest, and for us, we can see what has happened as far as the monkeypox is concerned, whereby it has to get to certain quarters before it gets declared as a public health emergency of international concern. So what we are saying here is that we should be empowered, as a regional health agency to really look at a threat that constitutes, that constitute a concern to our member state and be able to declare, public health emergency as appropriate. But of course, collaborating with the key stakeholders, working with partners, relevant partners, to come up with such a declaration. In terms of manufacturing capacity, again, the COVID-19 pandemic has clearly demonstrated that there is no way you can guarantee your air security when you have to rely on importation of these essential air security commodities to respond to outbreak. We've seen what happened.
I know he'll come back. He always does.
Richard, so I think my internet is so unstable. So let me wrap up in 1 minute. Yeah, let me just wrap up in 1 minute. So I think going forward, Africa CDC has clearly demonstrated the reason why it was set up in the first instance. We have our African Medicine Agency coming on board strongly. So we want and we need all the support to make sure that we fully operationalize these regional health agencies. Thank you, and over to you, Richard.
Okay, well, look, it's great that we saw you and heard most of what you had to say, which is excellent. Look, we've only got a few minutes. You've all been a brilliant panel. Let me hand over to Francine for a few final remarks.
Thank you, Richard. Oh, it has been a very exciting session, and we finished on time. And yeah, and deliverables such this series paper should be used as database on One Health situation worldwide, and progress should be monitored through repeated exercise. And again, and this One Health approach, we note that it has been endorsed by many countries, also in Africa, but the debate with all stakeholders and actors and the communities should continue for having really this approach implemented and adapted according to the local context. So, and yeah, and One Health has a high potential, to sustainably improve global health security for all by prioritizing national and local capacity building across relevant sectors and disciplines. So it has been really a pleasure to listen to these very outstanding speakers. So thank you for giving me the opportunity to attend such a wonderful meeting. Thank you.
Thanks, Francine, and let me add my thanks to everybody. We need more events like this. Note to Chatham House and all of our partners, because I have an avalanche of questions and comments in front of me that I've not been able to get to. May I also say, please read our editorial that goes with the series, because global health is very vulnerable to fashions, and One Health is not a fashion or a slogan. I hope you'll agree. It's actually the foundation for some of the most critical issues that face health today, from climate to AMR, just to name two. But let's not underestimate what One Health represents. It really is a fundamental philosophical shift in the way we think about the world around us. It's that important. Away from an anthropocentric view about health and towards a view that we should be striving not only for health equity, but also for ecological equity. But I'm going to end with a quote from one of our audience, because I think that this is a challenge to all of us. And this is from Rachel Cooper, who is the One Health policy lead at the UK Department of Health and Social Care. And she says this to challenge us: our traditional approach to governance and all areas of improvement is to integrate One Health approaches into existing instruments that often have human health origins. How can we be braver, she says? How can we be braver and start developing governance from a more equitable One Health basis. So not that One Health comes second, but One Health comes first. So that's our challenge: courage, bravery, and action. Thank you to everybody. Thank you to our partners. You've been brilliant and tenacious to stay with us for the past 2 hours. Have a wonderful rest of the day. Over.